Good evening, everybody. We finished the part one where we talked about the basic principles, including the anatomy, the consequences, and the types of gastrectomy. Today will be a shorter class, and it's also not going to be describing the gastrectomy technique in detail, even though we will touch on the salient aspects. Very practical as usual, and giving you certain what I can call pearls regarding gastrectomies and what are the things that we should be careful about. In the last section, we also have the immediate or the early and late complications that one can expect. They are actually, full classes by themselves. So I would just touch on it, have a rather superficial discussion, and leave it to you to do greater depth and go to greater depth by reading it up in all the standard books and other journals. Okay. So when we talk about resections, we have to free the stomach from its attachments. We talked about the ligaments in the anatomy part of it. So depending on what part of the stomach we take out, we have to release those ligaments. And when, of course, for a total gastrectomy or a subtotal gastrectomy, you probably take away all the attachments. The important things are to release the distal part of the stomach from up to the pylorus and the first part of the duodenum. That's when you divide the distal part of the stomach. For that, you have to take out the gastrocholic omentum and the lesser omentum. And the two main vessels that you take down are the right gastric and the right gastroepiploid. When you are taking out the part of the stomach, you're not worried about the vascularity for that part, so you can keep well outside the gastroepiploic arch up to the point where you decide the resection for the distal gastrectomy. Okay. When you're mobilizing the proximal part of the stomach, or when you have to get at the lymph nodes in a D2 resection, you will take the left gastric artery. And when you're looking at the fundus of the stomach and the large part of the body of the stomach on the greater curve aspect, you will take the left gastroepiploic and the short gastric arteries. When you're doing a substantial distal gastrectomy, the whole of the remnant of the stomach will be supplied only by the short gastrics. So you have to be careful to preserve it because you'll take out everything else that supplies the stomach. In a total or a subtotal gastrectomy, you depend on the blood vessels at the OG junction to come down and supply the remnant of the stomach. The stomach is necessarily a very vascular organ, so that it's almost impossible to get an ischemia of the stomach unless you have something drastic like a volvulus or something, which actually causes a lot of twisting and compromise of the blood supply. But by and large, getting ischemic problems in a gastric resection is unusual. Okay. When you're dealing with the removal of the stomach, there are a few technical issues. As I said, I'm not going into the depths of each kind of resection. That is something that you learn on the table or learn by watching videos of operative surgery. If you have specific questions on specific steps of the operation, you're most welcome to ask us. I'm here, Ravi is here. We'll be able to cover those aspects. So remember, stomach is very vascular, and so ischemia is rare, but bleeding is not that rare. Anastomotic bleeding can occur. And for those of us who do a single layer anastomosis, zero submucosal, or the extramucosal, in fact, my standard anastomosis is an extramucosal anastomosis. The exception is the stomach. When I deal with the stomach, on the stomach part of it, it has to be either a full thickness suture. On the bowel aspect, when you put the bowel onto the stomach, you can again take a zero submucosal or an extra mucosal stitch on the bowel aspect, but on the stomach aspect, it has to be full thickness or a standard 2-layer anastomosis with an inner full thickness layer and and an outer seromuscular layer. That is the important thing. Now, if, as I said, if you are taking the stomach out, whichever part it's coming out, you can take your sutures wherever you want. But if you're keeping the stomach part, for example, if you're doing a proximal gastrectomy, you have to keep the dissection outside the gastroepiploic arch, because in a proximal gastrectomy, you would have taken the short gastrix and the left gastroepiploid and the, as I said, the left gastric. And so the only thing that keeps the distal part of the stomach perfused are the right gastric and the right gastroepiploid. So you got to keep the dissection outside the gastroepiploic arch whenever you are taking the stomach, when you're retaining the stomach of that particular, in that particular segment. So as I said, all the major arteries that we know of the stomach can be taken when you're doing a resection, and still you can have a remnant of the stomach that will survive and the anastomosis that will heal well. That is not an issue as far as the stomach is concerned. Progressing in the same view, we have a concept of an angle of grief or angle of sorrow. Sanya, can you tell me what that is? Are you there, Sanya? All right, Ajay. Ajay, are you there?
Yes, sir. Yes, sir.
What, there is a concept of angle of grief or sorrow in gastric resection. It is they refer to it in other places also, but most prominently in the stomach. Do you know what that is?
No, sir.
No. Anybody else? Vinod?
Sir, most common leaks happens at the lesser curvature at the site of anastomosis because of right gastric artery division, because of ischemia in that area.
You're right. Okay. It's not necessarily right gastric or left gastric or whatever. When you keep stitching it, this is an area when you have a stomach remnant which is very wide and the bowel which is less wide or less smaller in diameter. You stitch up the stomach maybe half or 2/3, and then the rest of it is stitched, the bowel is stitched up to the rest of the stomach. But at this angle, where these two lines of sutures meet, is an area of relative ischemia. So you need to be careful when you do this anastomosis. 1 or 2 common steps that you have to take to avoid this is to make this a very acute angle. If it's an obtuse angle anastomosis, it's likely that you will not have ischemia. And second, you can bury that area quite effectively. If you bury that area quite effectively, even if there is some ischemia in the depths or the inner layer, your other seromuscular outer layer, which you have used to bury this initial layer, will protect the anastomosis from leaking. That is called the angle of sorrow. Okay. This goes without saying. You have all these important structures around. Left lobe of the liver, the CBD when you're dealing near the pyloric area, the spleen, the pancreas, the colon, transverse colon. So you've got to be careful when you do these resections, not to injure these adjacent organs. It becomes particularly important in the bulky tumors which have gone beyond the serosa, in which case, if there is a potential for a possible damage of these adjacent areas, you're better doing a multi-visceral resection. Take that area of the adjacent organ within your resection, and so that you don't have a problem with a damage. It's a controlled, a resection is a controlled damage, as it were. It's a controlled phenomenon. So you don't have an inadvertent damage of these adjacent areas. The going back to this angle of sorrow, there is one more solution for that, and that is to create what is called a Hofmeister valve. Any of you have heard of that word, Hofmeister valve?
No, sir.
Okay, so what they do is that this bowel is not only stuck to this little open area. The bowel seromuscular layer is sutured all along the cut end of the stomach, all the way. So you can imagine, if you can see my pointer, this bowel is taken up to this point at the beginning of the lesser curve cut all the way down without cutting the bowel. All right, it will just be a seromuscular suture to the stomach, but only where the stomach is open, this part of it, as I said, maybe a third of the diameter of the stomach, only that part the bowel is opened and sutured like everywhere else. So you have, instead of a local seromuscular cover to the anastomosis all the way across the suture on the stomach, you will have a seromuscular cover where the bowel itself gets opposed to that part. That's called a Hofmeister valve. All right, all the suturing can be hand or stapled. The only hint I'm going to give you about stapled anastomosis is you must use the correct thickness. By and large, an average stomach which is not hypertrophied, which is not thick, and the average small bowel, which is the most often anastomosed organ to the stomach, you use a blue, it's all color coded, a blue stapler. It's usually 3.5 millimeters height of the open staple. Okay, 3.5 mm staple. Whereas if the stomach is thick or in some way hypertrophy, you need to have a thicker anastomosis, thicker stapler, which would be a green stapler generally, which is 4.5 mm thick. So you must be careful about the kind of stapler, the cartridge that you choose, depending on the thickness of the stomach. Okay, we now go on to the next phase, which is the reconstruction options that are available. I told you that earlier we have three main concepts, three main sections of a gastrectomy. The first one is how much of the stomach you remove. The second one is how much of the lymph nodes you remove. And the third one is how you reconstruct after the resection. But before we go to this resection, can I invite Niranjan? You have any other comments to make about the technique?
No, sir.
Ravi?
No, sir.
No. Okay. So we go to the next section, which is any other questions or doubts from the students or the registrars?
No, sir.
No.
No,
Okay.
sir.
So let's go to the reconstruction part of what we do. The first one I've taken is the total or the subtotal gastrectomy. You have several options, and I'm going to mention the three common ones that we use. The first one is a Rulu. Okay, you take, this is the biliopancreatic limb. This is the DJ flexure. From there, you cut the jejunum, and the cut end of the jejunum is drawn up there, up to the end of the esophagus. Remember, this is a total gastrectomy. The two crucial distances that you have to have in mind are how far away from the the ligament of Treitz, okay, duodenojejunal junction, would you cut the jejunum? Any thoughts on that, Praveen? Any thoughts on that? How far away from the DJ flexure would you cut the jejunum? That is this part, this part is, sorry?
40 to 60 centimeters.
40 to 60. That's not correct.
20 to 30. 15 to 20.
About that, okay? Anywhere between 15 and 20 centimeters. The 40 to 60 refers to this limb. Can you see? This,
Yes, sir.
this is where you cut. This point, are you seeing my pointer? Are you seeing my pointer?
Yes, sir.
Okay.
Yes, sir.
So
Yes, sir.
this is where you cut. This was this point. and you drag it up there and stick it to the esophagus. Okay. And how far would you attach this cut limb to the jejunum? That is a Y. That is Y anastomosis. Y. This is 40 to 60. Why should it be 40 to 60? Why can't it be 15?
Biliary reflex.
Biliary reflux. And
reflex,
you're right. Yeah.
Tension.
But yeah, tension is not a big issue, but reflux is an issue. And biliary esophagitis is a crippling disease. Take it from me. It's a very, very bad disease. Why can't it be 120?
Absorption.
Absorption.
Digest.
Correct. You're right. So it's as simple as that. You want 150 or 160 or even 200 when you're doing a bariatric surgery, not here, where you want absorption to occur. So you draw a balance between the possibility of reflux and the possibility of giving the patient malabsorption. And the general balance is about 40 to 60. Okay. Now, if you have just a row Y anastomosis, what is its disadvantage? What is a primary characteristic of the stomach that is lost when you do a plain
Storage.
capacity, volume, not storage? Okay, you're right, but I think you used the wrong word, but your idea was correct. It is the capacity. You need to have some stomach holds food. Okay, storage is long term. This is short term. Anyway, so you can create an organ with a capacity. What you do is take a bigger loop like this, as you have seen, it's called the Hunt pouch. And then either you can do it by hand anastomosis. Here it's shown as stapler anastomosis. You double the jejunum on itself and then fire a stapler so that you open up that wall between the two loops of the jejunum, and you end up with 60 or 80 ml capacity neo-stomach, as you can call it, which is expansive. You know, you may start off with a small capacity, but with time, with eating, it expands. Generally, the length that you use is about 6 centimeters. That is shown here. Okay, so that's you can create a pouch. Now, this is my favorite. This is my standard after a total gastrectomy. It's a very simple thing. You don't have to do. Yes, Heli, Ravi.
See the colonic pouches. See, for example, when you do either sigmoid subtotal colectomy or even very low anterior section, because as you said, the capacitance of the rectum is lost when you do a low anterior section. It is said that it is, use the colonic pouch, and the function of the colonic pouch is usually optimized by about 1 year. After that, if you look at the quality of life of people who have had a direct colo-anal anastomosis as opposed to a colo pouch anal anastomosis, their quality of life in terms of the liquidity of the stools and continence and other things will all be same at the end of 1 year. Is it the same here also, or is the capacitance of the stomach helps the? Is there a difference in quality in terms of the?
Yeah, I get the question. The quality is the same. So the body doesn't miss the capacitance of the stomach. And the patient, I've seen patients with simple GJ or even this one that I normally do, just a loop esophagojejunostomy with a side to side jejunostomy about 30-40 centimeters from the esophagojejunal anastomosis. Okay, when you do that, it works the same as giving a pouch, and so one needn't necessarily do a pouch, but some people prefer to do it, and it's a surgeon's choice. The reason for this side to side jejunostomy, Samir? Are you there?
Hello, yes, sir.
Yeah, why do we do this side to side jejunostomy? We gave you the answer 2 slides ago.
Sir.
Same problem of reflux. If you did not do this anastomosis side to side, this is the duodenum, okay, duodenojejunal juncture here. So the bile will come here and reflux into the esophagus, and they'll get very bad esophagitis. Here, the bile will come here and take the easy route, which is the side to side anastomosis, and come down here. Food will come down from there, mixing of the bile and pancreatic juice, and food occurs in this part, the efferent limb. And so you minimize the chances of a biliary esophagitis. Okay. That is the purpose for this side to side jejunostomy. Okay. Have you understood the anatomy, the configuration that I have shown, Samir?
Yes, sir.
Ainas,
She's
are you
on
there?
emergency.
Yes,
She's
sir.
on
Emergency,
emergency
she's
duty.
not there. Okay, all right. Okay, so it's because it's important for you to understand this configuration, and it'll be difficult for you being first years, but go home and read it up again and see why we do what we do. Okay, and as a surgeon, these distances that we mentioned, they're not just theoretical mugging up. These are of practical importance, and so you got to remember that. Okay, and you fashion your anastomosis when you're on the table. Okay, after you now move on to distal gastrectomy, you're left with a stomach remnant. Okay, this is Billroth 1, which is a gastroduodenal anastomosis. Okay, done for benign disease. It's never done for malignant disease. Any reason why? Vinod, you want to have a go? It is not recommended. Billroth 1, which is a gastroduodenostomy, is not recommended for malignant disease, where resection is done for malignancy. Any reason why?
Because of tension, sir. Tension and the tissues will be.
No tension. No.
Margins could be positive, sir. If
Margins, you hope to get proper margins, but you're in the right track. It's not the margins, it's something else. You can get a recurrence of the disease. Usually it is in the bed of the stomach. Okay. So if you get a recurrence, around the pancreas, where and right next to it is the anastomosis. So the anastomosis can get blocked. And so you keep your anastomosis far away. Even if there is a recurrence there, the patient will not suffer from vomiting. So for reconstruction after resection for malignancy, the standard recommendation is Billroth 2, okay, which is a loop of jejunum here. It is a gastrojejunostomy. This is a gastroduodenostomy, okay. And it is true that generally, unless you have done a small resection for a benign disease like antrectomy, okay, we mentioned that we do an antrectomy, which is a relatively small resection of the stomach. We used to do is a better word, not we do. We used to do. There, it is easy to get the stomach remnant to the duodenum without tension. But you have done a fairly good distal gastrectomy for a cancer, then you can't bring down that area. That is another technical consideration. The afferent loop comes to, this is the duodenojejunal flexure. You take it that way and attach it to the remnant of the stomach. Even here, you can have that Hofmeister valve phenomenon where the jejunum is taken to this point itself, to the point of the lesser curve. That is also allowed. And this is a standard Billroth 2. Have you done any reading about the lengths and the routes for this kind of reconstruction? Vinod?
Yeah, there are two types of retrocolic and anticolic.
That's one, correct.
And the
Which
length is
one would you prefer?
retrocolic, sir.
Why?
The length will be short one.
Okay.
And the chances of compression of transverse colon will be in anticolic will be.
No, it won't get compressed. It's a very, very mobile thing. But I agree the afferent limb would be shorter in retrocolic. Okay, but what are its disadvantages?
In retrocolic, there is a chance of herniation, sir.
Correct. Higher chance of kinking also.
Yes, sir.
And even And if you have a long afferent limb, even there, it could
Biliary
be
reflex.
not reflex, but even there, because of the length, if it's there, it can undergo kinking.
Yes.
That's one of the problems with the long afferent loop. So it's a short afferent loop, isoperistaltic. That's another attribute that's given. What does that mean?
Sorry, sorry.
It should be the natural flow must be
Flow
in the
along the
direction of
peristaltic.
there is around the in the direction of the peristaltic wave. This is an isoperistaltic configuration. Whereas if you put this on this side, this corner, and the efferent loop comes onto the lesser curve side, that becomes an anti-peristaltic configuration. Not recommended. Okay? That's not recommended. All right. Are you with it? Yeah.
Yes, sir.
You understood that? Yeah. Now, if you guys
The
don't
one
understand, yeah, okay, please stop me and
sir,
ask me. Yeah.
the
Go on.
afferent loop here, is it joined to the CBD?
Yeah, that's a different. It's not joined to the CBD. It is a closure of the duodenal stump.
Okay, okay, sir. Okay.
Closure of the duodenal stump. It looks like that there. That's
Yes, sir, yes.
yeah.
Okay,
Yeah,
sir.
yeah. Okay, right. Now you can also have, instead of a Billroth, a Roux-en-Y reconstruction. Okay, same principle as in a total gastrectomy. Instead of the esophagus, it is the stomach remnant that you're dealing with. Same principles hold good. From the DJ flexure, this should be about 15 centimeters. And from the stomach, this should be about 40 centimeters. Okay, so that you do not have a reflux, because biliary reflux gastritis is also bad, just like biliary reflux esophagitis. This is also bad. Okay, this is another way you can reconstruct. And when you have a proximal gastrectomy, okay, if the resection is not very long, if you can bring the stomach up to the esophagus, you can stitch up that proximal end of the stomach and do a single layer anastomosis between the esophagus and the front or the back of the stomach. It could be either coming into the front of the stomach, anterior aspect, or the posterior aspect. In a second configuration, again a Roux-en-Y loop here. You do the same thing. This is the DJ flexure. You let the stomach, stitch up the stomach, the proximal end of the stomach. The gastric juice there, the bile and pancreatic juice will come in this biliopancreatic limb. Food will come from the esophagus into the Roux loop. Okay. And one modification that this is also stitched to the stomach here. Remember this. It's also stitched to that. One modification one can do is to make the food here in this middle figure, as you can see, food can either come down like this in the Roux loop, can also go into the stomach and come down like this. You can make all the food go through the remnant of the stomach by crimping here. You don't cut it, but you just, it's called a knifeless stapling. Don't cut it across, but just staple it, so that this loop of jejunum is blocked here. So the food from the esophagus comes into this loop of jejunum, all of it gets into the stomach and then into this loop and then enters the jejunum. Okay, so this is a configuration. There is no difference in any of these. Please understand, if you look at the literature, anticolic, retrocolic, Roux-en-Y or Billroth, there is no difference in terms of anastomotic leak, malabsorption, and most of the other parameters. The only thing that works well for these kinds of Roux-en-Y would be the biliary gastritis, okay, or a biliary esophagitis. That is the only situation where some people, that some people prefer the Roux-en-Y, but studies are completely devoid of any major differences in any of the complications that one sees in these configurations. So it ends up being a surgeon's choice as to what he wants to do with these. Okay. Now we come to the last section of this. Okay, before we go into it, any questions or comments, Niranjan?
Sir, nothing, sir.
Okay. Ravi,
I think the students have been, I think, spared of all the complications and the techniques of gastrojejunostomy. I think when we were doing the, the vagotomy and gastrojejunostomy, I think all those complications are now probably thing of the past. And the other comment is the fact that, once if you remove majority or most of the stomach, these people will definitely never become obese. They will be always underweight. They will be malnourished many times. So I think your comment about that you have to the optimal length of the bowel in which you have to anastomose becomes much more important, because they cannot actually tolerate any malabsorption at all. So you have to make sure you are very precise about this.
okay. So obviously, when you do a gastrectomy is a major operation, no doubt about it. So when you do that, you must be aware of the complications that may follow. And that forms the last section of my discussion today. The early complications soon after surgery, you have to, it's like any other surgery. Okay, bleeding, chest infection, anastomotic leak, intra-abdominal abscess, delayed gastric emptying, and post-op IVs. These are the things that duodenal bloat is another big thing, and that I would discuss under the intra-abdominal abscess kind of a situation. Bleeding is something which can be reactionary, as you can understand. Very, very important to have pre-op chest optimization and post-op chest physio after an open gastrectomy, particularly. Anastomotic leaks are relatively rare. We worry much more about leaks in colonic surgery than a gastric surgery. Delayed gastric emptying is a very real possibility. All right. It can also be because of inadvertent or even deliberate dip in a total in a subtotal gastrectomy or even a distal gastrectomy. You may end up dividing the vagus, and that is something that you should keep in mind. Post-op ileus can occur like in any other condition. And as I said, I'm not going into the details of these complications. You can read up about it, or if you want, you can have another separate section on it. But I put pancreatitis and duodenal stump blow as two separate issues. Pancreatitis occurs usually because of the handling of the pancreas, particularly many times it could be inadvertent damage of the pancreas. Or it could be that you have taken out an advanced tumor, carved it off the surface of the pancreas. That is also possible. When that happens, it can be a serious issue. Okay, particularly, it's very unlikely that you damage the major pancreatic duct. Most of the time, it will be self-limiting, but if you have done something with the pancreas, handled it repeatedly, it may be worth using octreotide, the somatostatin analog, just like you do it after a pancreatectomy. Duodenal stump bloat is a dreaded complication. All right, it usually happens. Okay, let me not talk myself about it. Let's bring in Nikita. What is duodenal stump bloat, and what are the predisposing factors for it?
Sir, usually during the Roux-en-Y anastomosis or any reconstruction, we close the duodenum, sir, in total gastrectomy or distal gastrectomy.
Correct.
Post-operatively, the closure opens up, and or the reflux occurs from the secretions pouring into the duodenal collection. As there is ileus, that will also propel the contents through the duodenum, sir. So,
what would be the predisposing factors for it?
that I'm not sure of, sir.
Think about it. All common sense. All surgery is common sense. What would make that suture line fall apart? What gives you anastomotic leak?
Decreased vascularity, sir.
Fine. So ischemia. So if you've taken away all the right gastric, the right gastroepiploic and all that, and you have a little stump there, which can become ischemic, that can blow up. What else? What can increase the intraduodenal pressure? Common sense again. Please, this is what I want you guys to keep thinking.
Efferent loop obstruction, sir.
Sorry?
Efferent loop obstruction.
Excellent. So what are the things that give you afferent loop obstruction?
Kinking or
Kinking,
JJ stenosis, the anastomotic site.
will it give you stenosis on day 4 or 5 when the duodenal blowout occurs?
I mean, narrow opening, sir.
Okay, technical issues where you have,
Anastomosis was
yeah. Okay, what else?
Long
Edema
afferent
at
loop.
the
Herniation of efferent loop, sir.
Very good. If you have a very long afferent loop, it can herniate or it can have a band obstruction. Okay, these are the 4 common ones, which gives you an afferent loop obstruction in the immediate post-op phase, and that can predispose you to duodenal stump. So what do you do when that happens? How do you diagnose it, and what do you do?
So that is why when they do the GJ, they would say either short loop or no loop posterior retrocolic gastrogenostomy.
Correct.
Yeah.
Correct. So how do you diagnose it? How does the patient present, and what do you do with it? Okay, I won't spoon feed you. I want you guys to read up about it and put it in a group. Put the answers in the group.
Clinically,
Okay.
patient deteriorates, sir. Ultrasound,
Sorry?
there will be collection.
Patient deteriorates, correct?
And when I'll ultrasound, then there will be collections, or if the drain is present, the
Mhm.
collection will be, the bile will be coming through the drain.
All right, good.
So if it is, we can wait for 12, around 1 to 2 weeks, sir. If it is settled down on its own, we can wait and watch.
Boy, you can't. You can't.
Can't.
If you have a collection there, and if you patient is septic, mind you, okay?
Yes.
And when the duodenum leaks, it leaks a combination of bile and pancreatic juice.
Okay.
All right, please remember this. If you have only pancreatic juice leaking, like a major pancreatic duct damage, for example, all right, pancreas releases enzymes which are not activated.
Yes.
Whereas when it gets mixed up with bile, alkaline bile juice, all these enzymes get activated. And so it can digest tissues. So there's no question of waiting with a duodenal leak. Okay? So
Yes, sir.
read up about what you do with a duodenal leak and then write about it. We'll discuss that some other time because I don't want to spoon feed you. Okay, I'll give you a hint that when there is a duodenal stump leak, okay, getting it closed is a challenge. And so there are techniques which are used to control the leak. Okay, and it's a phenomenon called a controlled duodenal fistula. So I already given you half the answer, but you find out how we do it. That is important. Read up the books.
Is there anybody up who can talk about duodenal stump management of duodenal stump leak?
Sanya, Ajay, registrars, you have to tell us.
the patient will have to be taken up, like depending on the patient's condition.
Mhm.
Like we said,
No.
first we is as the sorry, hello sir.
Go on.
No condition. You have to take them up. That is
Yes, sir,
Optimize.
yes, sir.
Okay, I'll grant
Yes, sir.
it
First
you.
optimize is what I
Optimize, yeah. Okay,
yes, sir.
Yeah.
all right.
Optimize, and then we'll have to take up the patient for the surgery. First, we'll have to give a thorough wash and take out all the contents, whatever is there, sir.
Right.
And
First,
then
Sanya,
we'll
first tell us.
yeah.
Sanya, first tell us how do you suspect and how do you diagnose duodenal stump leak?
Sir, usually duodenal stump leak
Vinod
happens.
gave a very hotspot answer. Yeah.
Yes, sir. Usually, duodenal stump happens around the 4th to 5th day of surgery, most commonly, sir. And here, patient will complain of a sudden severe pain in the abdomen, with features of peritonitis also. And patient can be in septic shock, like sir said, with respiratory distress as well. And also the drain, sir. What are the contents of the drain? It will tell us, and once depending on the contents of the drain and patient condition, we'll have to suspect, and investigations like ultrasound, we'll have to suspect that patient is having a duodenal stump leak. So then we'll once once we've diagnosed a duodenal stump leak, first we will have to optimize the patient since patient will be in shock, and then plan for a re-exploration as soon as possible. And when we are re-exploring, first we will have to clear out the contents, give a thorough wash, find out the stump which has opened up, and here the stump can be repaired in a few ways, sir. First, whatever the fistulous communication, if it is there, that is excised, and whatever the edematous part of the duodenum is there, the blowout part of the duodenum is there, that is removed, and anastomosis can be done.
Oh.
If there is any apparent,
Anastomosis with what?
so the whatever the part of the duodenum is there, that we will remove, sir. And
You
although
can't do that. You can't do
Tanya.
that, son. Not possible.
Tanya, never try to re-anastomose a blown out duodenum.
Reclose, yeah.
Never.
okay, sir.
Remember that.
That is exactly the reason. So I would like you guys to read up about it and put it up. Okay?
Yeah.
Yeah. Read up about it and put it up. All right. So we then come to the late complications, generally considered to be things that happen after 6 weeks. Okay. So bile reflux gastritis. That's one thing. In spite of all the things that you have done, you may still have reflux gastritis. It may not wait, I put it under late because it can happen early also, to be honest, but it becomes a real problem when it's going on for a few weeks. If it happens in the first 2 to 3 weeks and the patient empties the bowel well and gets back to normal activity, it may not trouble. But if the reflux persists for a long time, then it can be real trouble. That's why I put it under the late category. It can happen early also. Please remember that. Dumping early and late. What do you understand by that, Ajay? The two are different, and what are the mechanisms of early and late dumping? What happens to the patient?
Sir, in late dump in early dumping in early dumping syndrome, because of increased hyperosmolar contents in the food, especially the
Is
carbohydrates.
it hypo or hyper?
Hyper, sir.
Hyper. Okay, correct.
Yes, sir. There'll be a lot of absorption of water, and because of that, patient will have increased bowel movements,
No,
and he'll
not
have
bowel movements.
Diarrhea, sir.
Not even diarrhea. What is the prominent feature of an early dumping?
sweat,
Sweating.
Pain.
Sweat, pain.
We can also have sweating because of
Hypoglycemia.
pain.
Yes,
Okay.
hyper.
Yeah, glycemia phenomenon is late. In early, most
Dehydration.
pain is the main thing. Okay, because the fluid doesn't go in little bits. Antral mill. We told you the churning and the slow release of the churned up food through the pylorus is lost. So whatever he eats, it gets dumped into the jejunum straight away, absorbs water, it expands. The jejunum expands because of the absorbed water. And so like anything else, visceral pain, stretching of the jejunum gives pain. And it can also give, because of the pain, a reflex sweating and discomfort. Diarrhea and other things may occur, but not very common. Pain, postprandial pain is the main thing. So how do you avoid it?
Sir, we'll ask the patient to have a less carbohydrate diet,
Okay,
high fiber diet.
okay.
Uh,
Even more important than that.
Smaller meals, multiple meals.
somatostatin analogs will.
No, that's not required. Smaller, more frequent meals. Second one, and do not drink any fluids with your meal.
Food.
A common Indian habit is to have a lot of water with the meal. In fact, if you don't keep a glass of water next to your dinner table, there is something amiss. All right. So that habit they have to give up. Don't drink water with your meal. Have water 2 hours before or 2 hours after a meal. So don't have water with the meal. Okay.
Okay.
So those are the 3 simple things: frequent small meals, no water with the meal, and low carbohydrate meal. And what about the late? What is the mechanism for late dumping?
So because of rapid absorption of glucose, there will be a hyper. Hello, sir.
Go on. I'm listening.
Because of rapid absorption of glucose, there will be hyperinsulinic response, sir. Because of that,
Correct.
patient will go for hypoglycemia.
Why high hypoglycemia? There's food there, no?
Yes, sir. There will be rapid absorption of glucose will be there, sir. Because there will be
Correct.
spike in elevation of the insulin, sir.
Correct.
And because of that,
But
there
the
will
insulin stays much longer than the
longer.
glucose.
Yes.
That is the idea. Hyperinsulinemia is correct. The insulin stays much longer than the glucose. And so they end up with a hypoglycemia, which gives them sweating and features of tachycardia, sweating, and things like that. That is a late dump. The afferent and different loop syndromes.
Because of a long afferent loop, there will
Okay.
be a right after the meal,
Mhm.
there will be a pain for the patient, sir. And because of
The afferent loop syndrome is practically the same as the obstruction of the afferent loop. Okay, here, because of the relative obstruction of the afferent loop, duodenal blowout doesn't occur because it's further down, duodenum is well healed, but still you get a colicky pain. You understand? It doesn't drain into the efferent loop well, and so you get a colicky pain after food. Okay, colicky
Yes.
pain because food stimulates the pancreatic and biliary secretion, so the volume of secretion in the afferent loop increases, and so you get
Yes.
the pain. Efferent loop syndrome is where efferent loop is obstructed for some reason, kink or internal hernia that we talked about. Okay, and that gives them vomiting, again pain and vomiting after food. That's efferent loop syndrome. So typically, where are the situations where you can get an internal hernia? We mentioned one, which is the hole in the mesocolon. If you have a retrocolic configuration, you have a hole in the mesocolon, and in that hole, something may get in and get blocked. Another loop of bowel can get blocked. Where else can it happen?
Behind the roll limb, sir.
Sorry?
Behind the roll limb.
Behind the ruling, how does it happen? You're right. So why does it occur? What are the two structures between which you have a kind of a space where bowel can get in and affected? It's also described very commonly in the bariatric surgery. It's called the Patterson's hernia.
Last time. Yeah.
Okay. So please look up what it is and again put that in. What are the two structures between which the bowel gets stuck in this hernia? Okay.
Yes, sir.
Yeah. So you're right, it is the rulu, but where exactly does it happen? Is it important to know where exactly it happens?
Yes.
Is it just theory?
No, it is important.
Why?
Procedure when we go in again.
Correct. When you go in again, you must know where to look for the hernia. Okay, that is an important thing.
Or to prevent it from happening in the first place.
Correct.
Yes.
That's another good reason. Sorry, saying something, Nikita?
The same thing, sir, to fix it during the
Correct.
first surgery only.
Correct. So the other things that you can anticipate late are anastomotic stricture, anastomotic ulcer. All right. Why would anastomotic ulcer occur? Samir, I have not asked you to anything because I know it's your first years, but I think this is something you can answer.
Ainas, are you there? Is still in casualty or?
Yeah. Go ahead, Ainas. Sorry, go ahead, Samir. Why would somebody get an
Yes,
ulcer?
sir.
Samir,
Yes, sir.
just reason it out. Why would somebody get an ulcer, anastomosis or otherwise? What is the first basic requirement for an ulcer to happen? Peptic ulcer.
Irritation.
Sorry?
The irritation.
Irritation with what?
Sir,
Chilies. I'll give you multiple choice. Chilies, alcohol, hydrochloric acid, bile.
sir, because we are using the
All of the above.
All the
All
above.
of-
Acid, man. Acid is a basic requirement.
Yes, sir.
What is the treatment for a peptic ulcer? PPI, no?
PPS. Yes.
We all, please think, don't get flummoxed when we ask questions, either here in a class or, in the exam or whatever. Think it out. So acid must be there. So if you have an anastomotic ulcer, okay, you can end up saying that there is some acid exposure to that area. Okay, so to prevent that, how can you neutralize it with, what can you neutralize it with naturally without medication? Bile, right? So you can make the bile go to the anastomotic area and prevent the acid. But what is the downside of it? We've been talking about all along.
Bile esophagitis.
Yeah, biliary esophagitis, biliary gastritis. So we accept that we don't want that. That's a bigger nuisance. And if the ulcer occurs at the anastomosis, so be it. But the chances of ulcer occurring after a partial gastrectomy is very, very low. Why? We have given you all the answers. It's already discussed.
What have you removed, man?
What have you removed?
You remove this stomach itself.
Not the whole stomach, no, the distal
Antrum.
gastrectomy I'm talking about. It removed the antrum. A part of your distal gastrectomy is the antrum. So when you remove the antrum, what happens? We discussed all this. You should remember. There is no gastrin.
Yeah.
No gastrin, no acid.
No acid production.
Yeah. So generally, it's not that there is no acid at all, but it is very little. There are other methods, other things that stimulate acid. Again, go and read up about it. But the acid is very low. So the chances of an anastomotic ulcer with a partial gastrectomy is not very high, but can occur. It's not that it doesn't happen. These are
But
important. Go on,
remember that when you have anastomotic ulcers, they tend to be multiple. These anastomotic ulcers, because the jejunum is not used to taking the acid load, especially if there is more acid load.
Yes.
Deficiencies are very important. Hypoproteinemia, multiple causes. They don't have the stomach capacity, so they don't eat as much as others. And you can have weight loss because there can be, for the same reasons, they may have less protein and calorie intake. You also need acid to digest it. And as I said, there is a situation of a hypochlorhydria. So that will also cause nutritional deficiency. Iron deficiency anemia, same reason. B12 deficiency because of intrinsic factor. Okay, so all these things can happen, and you must have supplement. You must give them supplements. You should look out for all these things. Why would gallstone form? There's a higher incidence of gallstones compared to people who have not had a gastrectomy.
Vagotomy, sir.
Sorry?
Vagotomy. Hepatic branch is divided because of vagotomy.
That's one of them, correct. There is stasis. Basically, there is stasis, and the gallbladder doesn't contract and get rid of the bile as well as otherwise, and so end up with a gallstone formation. Okay, I think that cancer recurrence is not a complication, but it can happen if it's because of cancer. And I think that brings us to the end of our class. As usual, my favorite person is the Dalai Lama, and I keep on giving you quotes from him. I never get tired of it. All right, thank you very much. And questions and comments from the students first, and then Niranjan, and then Ravi. No questions, no comments? Ajay, you have to give something, questions or comments.
Sir, you said about Lauren Hunt pouch, pouch. Is
Right.
there any other pouch which can be created?
No, something like that, that's the only thing that they do. But just like if you want a bigger pouch, you can do an S or a W pouch, that like they do with the jejunum, with the ileum in the ilioanal anastomosis. Depends on, and you can have a longer pouch. Instead of 6 centimeters, you use 10 centimeters. It depends on what configuration you want to create the kind of capacity that you want.
Okay,
But it is not usually done at all. Not very popular.
Okay, sir. Okay, sir. Thanks.
Ajay, I think the answer to that, I think I quoted extensive figures for coloanal anastomosis, with the pouch, I think at best at 1 year, the quality of life is similar. So there is an element of improvement of quality of life in the first year. After that, it will be equal. But I think probably for the gastric pouches, probably hardly anyone does it. Initially, there may be help. After that, it will be the same.
Sir. Okay, sir. Thank you, sir.
Okay, Niranjan.
Sir, it was very good, sir. In detail, you have covered everything, sir, for gastrectomy.
But I must tell all the students and the registrars, you must read up about all those. We only touched on those complications. Nutritional deficiencies, afferent loop, efferent loop syndrome, duodenal bloat. Please read up about it. And if any questions.
Each of those complications can be a main question in theory also.
Correct. So read up about it.
Each of those
and,
complications.
if you have any doubts or questions, please ask us in the group and we'll be happy to respond. Final comments from Ravi, please.
I think it's a good continuation of the last class, a healthy discussion, and I think involvement of the students. And I think you have left a lot of them to read up. I think that is also important because everything cannot be. Shrikant keeps accusing us of spoon feeding the students, so I think you've done a good job of. Right.
No, I have asked you for 2 things to be put on the group, 2 answers. Please go ahead and do that, particularly the duodenal bloat. I would like you to do that. And thank you for your patient listening. Good night.
Good night, sir.
Thank you, sir. Good night, sir.
Good night.